Hello and welcome again to the Emergency Medicine Clinic's podcast. I'm Patrick Manley, the managing editor for the series here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles centered on a central topic. Today we'll be discussing the November 2015 issue on Psychiatric and Behavioral Emergencies. This issue is guest edited by Drs. Dick Quo and Veronica Tucci of Baylor College of Medicine. We'll be speaking with several authors from this issue and discussing their articles. Up first is Dr. Nidal Moukaddam from Baylor College of Medicine to discuss 3 articles that she co-authored. First, I'd like to touch on the Emergency Department Medical Clearance of Patients with Psychiatric or Behavioral Emergencies article that you co-authored with Drs. Tucci, Seaver, and Maturin. I find the down the rabbit hole and all the Alice in Wonderland allusions in the introduction of this article a really nice touch. Can you give me some of the key takeaways from throughout this article?
It really reflected our reality in the emergency room. We have a multidisciplinary emergency room. We are based at a level 1 trauma center. And the cases we get are very complex. They really epitomize the interplay between psychiatric and medical issues. And more often than not, we do not know whether the symptoms we are seeing are medical or psychiatric. We need to have a lot of collaboration and a lot of patience to be able to figure out those cases. And this is a chapter that represents our experience, essentially. When you read the chapter, you will have the impression that our specialties, emergency medicine and psychiatry, are different, but fundamentally they are not. We do cover the basis of what are the American Psychiatric Association and what the Emergency Physician Association say as far as recommendations, but what I'd like to point out is that we're not that different. Both our specialties say you have to evaluate and order as you see fit and order the test that makes sense. It's the practice that makes it so challenging. We have to make sure that patients with mental illness get treated fairly, but also that the emergency physicians and the psychiatrists feel like they have good support from each other. Because sometimes all you need is not a consult, but a curbside question or to know that you're doing the right thing and you're not missing an important condition.
Yeah, I've been handling emergency medicine clinics for about 10 years now, and we've never covered this set of topics in quite this way or this broadly.
Thank you. As I said, this is because we have a really good collaborative team and we work on a daily basis to make sure that our patients get the best care possible. It is very frequent that patients with psychiatric illnesses, mental illnesses, get dismissed quickly. So a patient who is psychotic and complains of chest pain might not actually get the workup that they need. And by adhering to ASAP guidelines, for example, what you're really doing is addressing the chest pain appropriately. And by adhering to APA guidelines, you're also making sure that this patient gets the proper care, both psychiatric and medical.
Next, I wanted to touch on your article on managing difficult patients, including those with personality disorders and somatic symptoms.
Oh, that's one of my favorites, yes.
This one you co-authored with Drs. Offer-Heidi, Flores, and Tucci. Can you give us some of the key takeaways from this article?
Absolutely. I think that the main takeaway from that article is that physicians and providers in general are not machines. And it is very important for us to appreciate how we make decisions and how our emotions of how when we're tired makes a difference in how we perceive problems. So in this chapter, we are focusing on personality symptoms. And when I say personality symptoms, it's not necessarily a full psychiatric diagnosis. It's just people who might rub you the wrong way because of the way they interact, or people who ask for medications or all the time, or people who, report suicidality, even though you know that what they really after is something else. This will also include people who will report complicated medical problems, and sometimes you're not quite sure whether it is really medical or psychiatric. So this is a chapter that talks about the difficult patients that you encounter in every flavor and variety. Our patients come to the emergency room and, they've never met us before. We do not know them. However, they do expect us to have a crystal ball and to actually read into their mind. They actually expect us to understand why they're having worsening pain or why they're having those symptoms that don't make sense together. And what our chapter does is basically guide you through what could it be organically. If it's a medical issue, what could it be? But if it's not a medical issue, what are the best tips to deal with it and how to handle this patient so that they're happy and you're happy?
And lastly, for the article, New Drugs of Abuse and Withdrawal Symptoms, the one that you co-authored with Drs. Andrabi, Green, and Lee, you tackled a group of drugs that we have not really covered much in the past. Can you tell me a little bit about what these new drugs are? I'm sure we all remember the bath salts epidemic that was so popularly covered in the news in the last few years.
Yes. Over the past, I'd say 5 to 10 years, we have seen a host of new drugs that have come out and that have really flooded the market. And they have been really difficult to deal with because they're a moving target. In our chapter, we've covered drugs such as bath salts, which are basically derivatives of stimulants. The chapter will take you through a history of stimulants and how the new ones differ, both in physiological effects, but also in what you might see in the ER. Also, we cover synthetic cannabinoids, and these are a very scary group. They're much more potent than marijuana. They're devastating in their effects, both physical and mental. And to date, believe it or not, there are about 400 that are on the market because they keep making new ones, and it's really, really hard to target. We do cover the symptoms, what you might expect when somebody comes in the ER. It is important to know because these drugs are not typically detected by a traditional urine drug screen, and so you really are relying on your clinical sense and your history taking to know what the patient's taken. Lastly, we cover drugs such as NBOME, NBOME, and this is a serotonergic drug that a lot of people are confusing with LSD. Very interesting compound, and I'll give you a hint. It's the metallic taste that differentiates it from LSD. So people will think they've used LSD like they did in the 70s, but they have not.
So that's really interesting. Is there a great incidence of cases where people did not even know what they took?
Absolutely. We're seeing that a lot, and it's really scary. The patients will not know what they took. They might have some drastic reaction. They might lose consciousness. They might have a seizure. They might develop hyperthermia. Tachycardia is one we see a lot. And when they end up in the ER, because these drugs are new, again, as I said, they're a moving target, we cannot test for them. And some of those tests are available. It's just that the drugs could be new. It's a drug that could have been just a bad batch, flooded the market today, and it's pretty much local. We do have a lot of similarities between big cities, but I would say this is difficult for the emergency physician to manage unless they take a very, very good history and possibly collateral information. For example, if the police officer brought the patient, you do want to ask them if they found a package on the scene or what they think the patient took.
I just wanted to take a quick pause here to let our listeners know they can receive an exclusive discount on the issue we're discussing today by visiting us.elsevierhealth.com/EMC podcast. Joining me now is Dr. Nathan Allen to discuss the article Ethical Issues in Emergency Psychiatry he co-wrote with Drs. Khan, Alzari, and Stoller.
Thank you very much for having me.
I hoped we could run through some of the key takeaways from your article, starting with the section on capacity and consent.
Yeah, absolutely. Capacity is a challenging issue in emergency psychiatric care because such a large percentage of patients who need inpatient hospitalization will be incapacitated, as well as the fact that psychiatric conditions are some of sort of the many medical conditions that can generate a state of incapacity. And so I think it's important for emergency physicians to be aware of the need to be making a capacity assessment on many, if not most, of their patients presenting with a psychiatric illness, and to try to do that in a structured manner while knowing that this is something that any treating physician can do, and so isn't something that's solely in the domain of a psychiatrist.
Yeah, I feel that Table 1 especially really broke down the different elements of that very well.
Right. And what we're looking at there is what was kind of seminally originally described by Applebaum and Grisso, and that's the 4 parts of assessing decision-making capacity. The first of which is the ability of somebody to communicate a choice. The second is their ability to understand the information as it's pertinent to them. And you assess something like that by asking someone to, restate what you've just told them, to summarize what you've told them or otherwise. And then looking at their ability to appreciate that information applies to them. And so you can do this by asking them to talk about, what they anticipate may happen if they do or don't do this thing. And so just sort of the difference between understanding what you've told them and recognizing that directly applies to them. And then the last step is their ability to reason in a manner that can be interpreted in light of their goals and values to arrive at a choice. And it's important here that this doesn't have to be what you view as the best choice or the most reasonable choice. You just need to be able to follow a reasonable plan that the patients used to go from the information to the decision that they're making that seems consistent with their goals and values.
The brief section that focuses on what to do when patients make threats against specific persons was really interesting. Can you take us through that a little bit?
Sure. There's a lot of areas that emergency psychiatric care and the law overlap, and a lot of these are going to be jurisdiction specific. And so there's kind of three major areas that I think it's important to know the law relative to your practice and your jurisdiction. And one of those is the one that you mentioned, which is your jurisdiction's what we often call Tarasoff laws, based on the Tanya Tarasoff case, in which substantive threats were made by a person with mental illness against a identifiable person who ended up later being murdered. And so certain states, but not all states, and so this is very jurisdiction dependent, will have laws or regulations concerning notification of individuals that are identifiable and to whom substantive threats have been made against. In addition to into Tarasoff laws, I think the other two areas of law that it's good to know about in your jurisdiction relative to emergency psychiatric care are the jurisdictional laws regarding involuntary commitment or involuntary holds while in the emergency room and who can do that, as well as the laws regarding surrogate decision-making, specifically as it relates to consent for certain types of psychiatric care, as many jurisdictions have carve-outs that exclude certain types of psychiatric care from the standard authority of surrogate decision makers when patients are incapacitated.
And the last major section I wanted to touch on is a section on ethical issues in forced medication, restraint, and seclusion. What were your findings here?
Yeah, absolutely. I think this is a major area that we deal with frequently in the emergency room and one that's consistently challenging. And when I think about involuntary treatment, try to think about kind of four broad categories in which that can come up for patients with psychiatric illness in the emergency room. The first of those is patients who have a separate medical condition requiring treatment but are incapacitated due to psychiatric illness. And those patients can be managed in a very similar manner to people who have lacked decision-making capacity for other reasons, but at times requiring a little bit more work in terms of explanation and trying to help generate compliance with treatment and produce a good outcome for them. The second would be involuntary admission, and I think the ethical consideration here is recognizing that the goal of an involuntary admission is to try to treat dangerousness that's stemming from mental illness and the dangerousness that is going to be treatable or amenable or improvable with a hospitalization. And then controlling sort of acute behavioral crisis. And this is a challenging situation in which you're trying to balance a variety of legitimate ethical concerns. On the one hand, you have the patient's autonomy rights, and then the other legitimate and significant ethical consideration is their safety as well as the safety of staff and other patients in the emergency department. And in those situations, I like to think about trying to progress through an escalating treatment strategy that I think is both commonly used in terms of its clinical escalation, but also has an ethical component to that escalation, which is moving from asking to negotiating to telling people what needs to happen, then through a show of force, and then in situations in which that's not effective, to use of medications to try to help alleviate the effects of the behavioral emergency, or when necessary, restraint or seclusion.
Are there any situations that you've experienced personally in your work that have informed some of the directions that you've explored in this article?
Yeah, no, definitely. I think both as an emergency physician and then also in some of my work separately as an ethics consultant, I've seen the long-term distrust that can be built in patients with chronic mental illness by repeated involuntary hospitalization or involuntary treatment, whether that's sort of medication administration, restraint, or seclusion. And I think that has both detriments to their health and their ability to improve over the long-term course of their illness, as well as making it more challenging to work and interact with those patients in the emergency room. And so, because of that, I've tried really hard in my day-to-day practice to really consistently work the process of gradually escalating therapies, of really making an effort to try verbal redirection, to try continued negotiation in any situation in which safety isn't an immediate concern.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on psychiatric and behavioral emergencies, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. A CME program is also available. For more information, visit info.theclinics.com. Be sure to follow us on Twitter @eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes. Upcoming issues of Emergency Medicine Clinics will focus on respiratory emergencies in February, abdominal and gastrointestinal emergencies in May, and in August, geriatric emergencies. Thanks, and we'll see you next time.